All right. So last time, we left off talking about bone cells, osteoblasts, osteoclasts, osteocytes, etc. So this time, we're going to start with lots of vocab. So we're getting on into the structure of cortical or compact bone. So in conceptualizing compact bone, one of the ways that we often talk about it is that the functional unit of compact bone is called an osteon. So very similar to what we talked about with skeletal muscle, where the functional unit of skeletal muscle was a sarcomere, and then you had those repeating series of actin, myosin, Z-line, etc. Very similar concept here. So with an osteon, there are a few components. The first is that there is a central canal. And so what you've got on the picture there on the far right, that is a single osteon. So you got a central canal, and that central canal houses an artery, nerve, and vein. So the artery is the red thing, the nerve is the yellow thing, and then the vein is the blue thing. Arteries deliver oxygenated blood, veins bring deoxygenated blood back to the heart, and then nerves control, in this case, they're going to control sensation in bones. So that's the central canal. So that's also known as the Haversian canal, for the anatomist who named it. And then around that canal, essentially forming that canal, you have what are referred to as lamella. And so what lamella are these rings of bone, or rings of osseous tissues, another way of thinking about it. Sorry. I just swallowed wrong, I promise. I don't have anything going on. So you've got these rings of osseous tissue. And so you've got a ring with a relatively small diameter around that central canal, and then you have another ring outside of that with a slightly larger diameter, and then another ring with a slightly larger diameter around that. So you get this series of concentric rings, and each of those rings is a lamella. So one of the things about those rings that I want to point out is you can see these little collagen fibers, right? And so remember that the collagen is secreted by our osteoblasts. So they secrete the collagen. In the case of bone, the collagen serves as sort of a scaffold. So it is the basic thing that we build upon. And so you've got on this innermost lamella, these collagen fibers that run from high to the left to low on the right, and all of them run the same direction in that particular lamella. And then once we've got that collagen scaffold, we're going to take calcium phosphate, and then we're going to put those calcium phosphate molecules in between those little collagen fibers. And that's what's going to give bone its hardness, is the deposition of calcium between those collagen fibers. That's what makes bone the dense tissue that we recognize. So one of the things that you probably have noticed then is that on the next lamella, so the slightly larger one, the collagen fibers run the opposite direction. The reason that matters then is that makes bone resistant to a variety of torsion or twisting forces. So one lamella is resistant to torsion from, let's say, left to right, and then the one outside of it resists twisting the other way, right to left, right? And so that's one of the things that gives bone its structural integrity there. So those are our lamella. So again, that's one osteon, central canal, and then series of lamella. All right, so then if we look at cortical bone more broadly, so we pull back a little bit, you'll see that you have these series of osteons. If I can pull out my mouse. So here's one osteon, and here's an adjacent osteon, and then here's another one, right? And so you've got all these circles that touch each other. Between them, you have what are referred to as interstitial lamella. So they are ones that are not round. So they're just kind of placeholders. They sort of fill in the gaps between the circles. That's what interstitial lamella are. Circle. Oh, yep.
I'm sorry.
Sure.
I don't think that bottom that hiding in there,
Yep. So here's one lamella, here's another one, and all of these together are an osteon. And then between them, so like this little area here where the circles all kind of touch, but there's a gap, those are your little interstitial lamella. Is that what you're asking? Okay. And then we got circumferential lamella, which are the ones underneath the periosteum, which remember is the outer covering of the bone. And those are these big ones right here. So they have a really large diameter. They're again on that outer or more superficial surface of the bone. Those are your circumferential lamella. A few other important things. So canals and canaliculi. So we talked about the central canal. So that's in the middle of an osteon. And then you have what are referred to as Volkmann's canals, or the other name for them is here as well, perforating canals. And so those run at a 90-degree angle to those central canals. So the way that bone gets the circulation, or a lot of the circulation, so there are some arteries underneath the periosteum, but there are also a few pores in the bone where an artery enters the bone, right? And then that artery branches out past that point. And so all of these are branches off of that artery, okay? So those are our perforating canals, again, or Volkmann's canals. Those run at a 90-degree angle to that central canal. Canaliculi, an important term that goes with them is lacuna. Lacuna means small lake. So, and here we're looking at this, and I know it's not the most helpful because the picture's kind of small, but so again, central canal here, here's one lamella, here's another one, here's another one, here's another one. And so between them, though, you can see that there's this darker color here, and then these little purple dots, which I don't know how you can see from where you're sitting, but there's these little purple dots in there. Those little purple dots are your osteocytes, which remember are your mature bone cells. And so effectively what happens is the osteoblasts secrete the matrix, and then they maintain contact with each other. So one osteoblast is actually attached to another osteoblast, okay? So they're going to secrete this matrix, and basically what they do is they paint themselves into a corner. So they lay down all of this collagen, and then we crystallize all of that collagen with calcium. And so now those osteoblasts are separated from the ones in the closer lamella by this wall of calcified tissue. But to keep them from being completely separated, we have canaliculi. And so what canaliculi are these little bitty, if I can bring up my mouse, there we go, these little bitty holes, if you will, in that ossified tissue that allow, so the darker stuff there is extracellular fluid. It's mostly water. And so what ends up happening is your osteocytes, your mature bone cells, still need certain things to live. So they still need oxygen. They still need to get rid of carbon dioxide. They still need glucose. They still need amino acids. So how could they possibly get that if they're walled in by bone? And the answer to that question is all of those things that they need, oxygen, amino acids, glucose, etc., are going to diffuse from that central canal. They're going to leave your arterial circulation. They're going to diffuse out here into this extracellular fluid, and then they'll move through those little canaliculi to eventually make their way to those osteocytes. So those canaliculi allow for the osteocytes to get the things that they need to continue living. So those canaliculi are pretty important. Other things about the osteocytes. I mentioned this last time, but they are connected to each other. So this individual osteocyte here is connected to this one here. They have dendrites, which are these extensions, and so they are physically connected to the osteocytes around them. And where there's a physical connection between them, they're what are referred to as gap junctions. So gap junctions are basically doors that are always open. And the reason that matters is one of the jobs of the osteocytes is to communicate about the health of the bone, or not necessarily health of the bone, but mechanical compression of the bone or mechanical tension on the bone, right? So if bone gets compressed, that does some microscopic damage to the bone that has to be repaired. And so what happens is when the osteocytes are compressed, that opens up mechanically gated channels, and that changes the charge of the cell. So on the compression side of the bone, so if we're thinking about the femur, when you stomp down or when you press down, you're going to get compression on the medial aspect and tension on the lateral aspect. You're going to push down on the inside, and there's going to be pulling apart on the outside. So when you compress on that medial aspect, that's going to open up some of those voltage-gated channels, or mechanically gated channels in that case. And so that's going to allow an influx of calcium inside of those cells. And so then that diffuses across the osteocytes, and that's one of the ways they communicate with each other, but also one of the ways it initiates the signaling cascade with the osteoclasts about, hey, there may be some damage here that we may need to repair. So they are physically connected to each other, and they communicate with each other directly through those gap junctions and through the movement of those charged particles. And as an aside, before I forget, if you go to the anatomy app, I go all the way back home. So if you go under models, there's a little bone cross-section model, which is the one that you're looking at here. And so if you want to actually try to find all the stuff we talked about, so you can find like periosteum, and you can take that off, find your bone marrow. So I would, if you're bored, this model is pretty cool. You can find all the stuff that we just talked about. All right, so moving on. So that's compact bone or cortical bone. The other type of bone we talked about last time was trabecular or spongy bone. Remember that your trabeculae are those things that kind of look like the spider web. So they, in the case of a flat bone, like the one that's pictured there, they run between the layers of cortical bone. And so one of the differences there is that they don't have osteons. They don't have these cylinders of hard tissue. Instead, they're all just sort of irregularly arranged. They're sort of kind of like those interstitial lamella, where they don't have any particular shape to them. And so with them, there isn't the same canal system either. So if we look at it close up, so that's an individual little trabeculae. So you can see that you've got rings, kind of, but not exactly cylinders, of calcified tissue, and then osteocytes between them. And then on the outermost layer, you've got your osteoblasts here, and then also an osteoclast. And so remember that those trabeculae align along the lines of stress. And so if that bone is being pulled apart in one area or being compressed in one area, we can lay down a new trabeculae, or we can change the shape of the trabeculae. And we can do that, we can add more or make them larger by increasing the activity of our osteoblasts. They'll lay down more collagen, and then eventually we'll crystallize it. Or if we've changed the way that we use this bone and we don't need those trabeculae anymore, then the osteoclasts, we can get more of those, and then they'll just break it all down. So that's one of the ways that we can remodel those. What is the layer of tissue, calling back to last time? So here's our little osteoblasts. So under what layer of tissue do they sit? We talked about periosteum on the outer covering of the bone. Anybody remember what the covering of the trabeculae is? Starts with an E. Sorry? The endosteum, very good. So they sit underneath the endosteum. All right, so we've already kind of touched on some of this stuff. So bone is a combination of organic and inorganic components. So the organic components collectively referred to as osteoid, which you can see there is the ground substance, so largely fluid, and then the collagen fibers. So I think this textbook and then journal articles you read on talking about bone talk about that the osteoblasts generate osteoid. So not only do they lay down collagen, but they also lay down some of that extracellular fluid and extracellular proteins as well. One thing that is useful to know is that between those collagen fibers, you have what are referred to as sacrificial bonds. So one of the things that bones are not really good at, but they're somewhat good at, is dissipating forces. So whenever you, like during normal walking, when you are in what's referred to as mid-stance, which is when all of your weight is over one leg, so when I'm just standing directly over one leg, during a normal gait cycle or during a normal step, you're going to bear 3 times body weight on that leg, right? Just from the impact and then the force moving over. So bones have to be able to absorb a pretty significant amount of force. So if it's 3 times body weight during normal walking, imagine what happens when you're running, or if you're just, like doing plyometrics and doing box jumps and stuff. Pretty significant amount of forces the bones are going to have to absorb. So one of the ways that they do that is, again, they've got these sacrificial bonds between the collagen fibers. So when the bone gets compressed, we can get where some of these little collagen fibers will snap. And so what that does is that helps dissipate the forces. As those fibers break apart a little bit, you get some more give to the bone. And so that helps spread those forces out so that you don't get larger cracks between those calcium crystals. So it helps prevent, you essentially get, it's not exactly a microfracture, but you get some breaking of those bonds to prevent fracturing of the bone. And then the inorganic components, the calcium phosphate crystals. So again, we lay those down between those collagen fibers. All right, so here's where some of that stuff matters. So we're going to pretend that you're a coach or something. I don't know. We'll say you're a running coach. You got an athlete that's coming and talking to you. He's a 22-year-old male, and he has been preparing for a marathon. And so we're going to say that it is a late summer marathon. It'll be here in Wisconsin. Oftentimes the marathons are like in August and September. And so we're going to say it is March. And so he has gone from running a little bit on a treadmill inside to now the weather is getting nicer, so he's running outside all the time. So he's changed surfaces, and he has dramatically increased his mileage. He's gone from running 10 miles a week to 30 miles a week because weather's nice, he likes being outside. Since he's done that, he has had progressively worsening groin pain. So the groin pain is it's sort of on the anterior, but mostly on the midline. And he notices that the pain is worst late in the runs and then has progressed to after the runs for longer and longer periods of time. So initially, he had some groin pain after the run, go away. Now it's kind of late in the run and progressing to earlier in the run. So initially, let's say the pain started around mile 12. Now he's starting to get pain around mile 10. And then it's lasting for an hour or two after the exercise. And it's gotten to the point where it hurts almost all the time now. Like with every step, it's really painful, and he started to limp. So what do you think could be going on? Any guesses as to what his injury is? Kind of related, well, it is related to what we're talking about. He's got a stress fracture. One of the things that if you ever get into sports medicine, physical therapy, when people come in with groin pain, that is one of the most vexing things ever in sports medicine, because groin pain could be a low back issue, could be a knee issue, could be a fracture, could just be that their groin muscles are tight, could be a problem with their pubic symphysis, the cartilage on the front. So there's all kinds of stuff. So whenever people come in with groin pains, like, oh man, because like I said, there could be all kinds of different stuff going on. So his groin pain is pretty non-specific. But what is one thing that I did give you there that's pretty classic with stress fractures is that they're going to hurt after a little while in the exercise. And again, that's going to progress to earlier and earlier in the exercise and later after the exercise. One of the other things, not necessarily with hip stress fractures, but stress fractures elsewhere, oftentimes they can point to the specific spot. So last time we talked about shin splints, and typically if you ask somebody with shin splints, like, where does it hurt? They're like, all of here, right? They basically point up and down their shin. If they have a stress fracture in the tibia, which is the second most common bone to get a stress fracture in, they're going to be like, it hurts right there. And so if they tell you one specific spot, now you're thinking stress fracture rather than thinking shin splints. So anyway, what I gave you is a femoral neck stress fracture. And so one of the things about this, as it relates to the last slide, so thinking about the sacrificial bonds. So again, the bones have the capacity to allow some of those collagen fibers to break and then to repair them. But they can only repair them if there's a sufficient amount of downtime. So as you know, you make a lot of your gains, if you will, during rest. You repair the body so that the next time you go out and exercise, you've adapted to the initial exercise stimulus. So if we have somebody that goes out and just dramatically increases their volume, they're going to do some damage to the bones, but if they let the bones rest, they'll be able to repair them, right? But if they go out and they run today, 20 miles today that they're not used to, and then another 20 miles or something tomorrow, the bones don't get a chance to repair themselves. And so if you do that over and over and over, then that becomes a fracture. So that's what's referred to as a stress fracture. So in this case, he has one actually on the superior part of the neck of the femur. You can see the little gap there. So stress fractures in the femur are most of the time actually on the compression side. So they're on the inferior aspect of the femur. Those repair better. So the fracture I gave this guy, or the fracture I'm showing you here, is actually a more problematic fracture. So fractures that appear on the tension side of the bone, where it's being pulled apart, don't tend to heal on their own. So somebody that gets a fracture like this, what they're probably going to have to get, I forget the exact name of it, but it's a screw that runs through, it actually runs through most of the proximal part of the femur and then into the femoral neck to try to pull those two fracture sites together. Otherwise, this one tends to not heal because it's hard to, two surfaces are being pulled apart without bringing them back together, like stitches do for a similar concept. They're not going to just grow back together on their own. So this is one of the more problematic stress fractures. So, for your own purposes, and this is actually usually a good talk like right after the new year, like don't go from doing nothing to doing a whole lot of everything, because then you get tendonitis, you get a variety of overuse injuries, but one of the more common ones in endurance sports are your stress fractures. All right, so let's talk about growth plates. So, as mentioned last time, bones grow in two ways. Long bones grow in length at growth plates, and that's what's referred to as interstitial growth. So interstitial, I-N-T-E-R, inter, and then S-T-I-T-I-A-L. T-I-A-L, interstitial. And so interstitial growth is growth that happens at the growth plates. As opposed to appositional growth, and appositional growth is just spelled AP and then positional, appositional. So appositional growth is where bone grows in width. So interstitial growth is growth in length. Appositional growth is growth in width. So what we're talking about here is interstitial growth. So growth of the long bones at the growth plates. Remember the more medical term for that, or more appropriate anatomical term, is the epiphyseal plate. And so remember, those are distal to the epiphyses, that's in the metaphysis of the bone, and that is a plate of hyaline cartilage. So you see the 5 zones there. So one of the things my graphic and my little slide don't exactly match up, because on the graphic here it has resting zone, doesn't have a number, but I gave resting zone number 1. So just in case you're looking at it, you're like, wait a minute, those don't match. That's why. So anyway, just pretend like the graphic on the right has a number 1 at resting zone. Add 1 to each of those numbers. So where everything is, so what you're looking at here, so this is our, we're going to call this the proximal aspect of the humerus. So the one right there about where the anatomical neck of the humerus is, you've got a growth plate right there. And so this is closer to the humeral head up here. And down here is closer to the diaphysis, or the shaft of the humerus. So on the epiphyseal end, closer to the end of the long bone, that's where you've got your resting or quiescent zone. And so there, nothing's happening. But underneath that is the proliferation zone. And so remember, this is hyaline cartilage, so we're talking about chondrocytes, cartilage cells. And in the proliferation zone, if something proliferates, you make more of it. So I said chondrocytes, but in this case I'm actually talking about chondroblasts. So your chondroblasts, your immature cartilage cells, are going to make copies of themselves. They're going to undergo mitosis, so they're going to split and make an exact copy of themselves. So that's what's happening in the proliferation zone. More copies of chondroblasts. If something hypertrophies, of course that means that it grows, because we've talked about muscular hypertrophy. So in the hypertrophic zone, those chondroblasts are going to get larger. And they are going to lay down lots and lots of extracellular matrix. And they are very briefly going to mature into chondrocytes. And then we're going to get calcification of that extracellular matrix that the chondroblasts, eventually chondrocytes, have laid down. So they've laid down a bunch of collagen, and we're going to start to put calcium phosphate crystals on those collagen fibers. And so what happens then is, as we lay down all of that calcium, kind of like we talked about with the osteocytes, where they sort of paint themselves into this hole of calcium all around them. And so the chondrocytes don't maintain contact with each other like the osteocytes do. And so that sort of painting themselves into a corner, surrounding themselves with calcium, actually inhibits their ability to get the oxygen, the amino acids, the glucose that they need. And so then those cartilage cells die. So once those cartilage cells die off, then we get, so now we're down to 5, the ossification zone. Then we get osteoblasts, so immature bone cells, start moving to the area. And so then they start laying down extra collagen and then crystallizing that collagen. But again, they maintain contact with each other. So they continue to get the things that they need in terms of oxygen, amino acids, and glucose. And so then that's your ossification zone. And so what you end up getting then is the trabeculae of spongy bone that forms there. So initially it's spongy bone, and then we remodel it as we age to become cortical bone on the more superficial surfaces of the bone. So I mentioned last time that kids are more susceptible to certain types of fractures, that the growth plates are the weakest part of the bone in kids. And so the specific spot is in this zone, the calcification zone. Because you've got that transition where the cartilage cells are dying, they don't have good access to oxygen, so they're weaker cells. You've got this sort of immature matrix, but the osteoblasts haven't moved in yet, so the calcification of that tissue isn't very good yet. So that's the weakest spot in the plate. So oftentimes if kids get growth plate fractures, it's in that part of the growth plate. This stuff you don't need to know, so don't worry about writing it down. So in terms of regulation of bone growth, so when kids grow, when they hit that growth spurt when they're like 6 or 10 or whatever, those growth spurts are regulated by growth hormone. And then whenever they hit the adolescent growth spurt, so for girls, sometime around the age of 11 to 13, for boys, a little bit older, 14 to 16, those are determined or those are initiated by the sex hormones. So in boys, testosterone, and women, estrogens. And for that adolescent growth spurt, testosterone and estrogen both result in closure of the growth plates. So throughout childhood, with periodic releases of growth hormone, we're going to increase the length of the long bones. You'll get proliferation of those chondroblasts. And then you get that for a little while with testosterone and estrogen, but eventually it results in closure of the growth plates. Thyroid hormone regulates the production of growth hormone. So there's that. And then the reason I mentioned this is I wanted to talk about it. So you can have a disorder of growth hormone, which is results in gigantism. So the most famous individual with gigantism that I'm aware of, Andre the Giant, pictured there on the left. So he was billed at 7'4" and 520 pounds. So an enormous human being. So that picture doesn't, Hulk Hogan there on the right is also a pretty big guy. So that picture doesn't really do him justice, but I think this one does. So that's an actual normal sized beer can that Andre the Giant's holding on the right. And you can see how big his hand is relative to the beer can. The guy on the left is a pretty big guy himself. He was about 6'3", 250. So that's a pretty large sized individual on the left anyway, and just how much bigger Andre the Giant's hand is on the right. So that's the result of excess growth hormone production. All right. So in terms of bone remodeling, I'm just going to skip over that. We're going to go to this. So there's two controls of bone remodeling. So the first is a hormonal control, and then the second is in response to mechanical stress. So we talked about parathyroid hormone last time. Does anyone remember what it does? And if yes, I'll be impressed. No, no, okay. So parathyroid hormone helps increase blood calcium levels. So remember that we need to maintain blood calcium within fairly narrow limits because we need normal levels of blood calcium in the extracellular fluid for nerves to function and also to help regulate heart rate. So if our blood calcium falls too low, then that can cause arrhythmia in the heart, it can cause muscle twitches, and a number of other things, dysfunction of the nervous system. So we have to have a certain amount of calcium available in the extracellular fluid when we need it. We can't let that fall too low. And so again, the bones are essentially a bank of calcium. And so if your blood calcium drops too low, that'll stimulate from a endocrine gland in your neck, the parathyroid gland. That'll stimulate the release of parathyroid hormone. That then circulates in the blood. Parathyroid hormone stimulates the activity of the osteoclasts. And so remember, the osteoclasts break down bone. So in response to parathyroid hormone, what they'll do, and where the osteoclasts largely sit, is in that trabecular bone. So backing up a little bit. So your osteoclasts are largely going to be in here, in this trabecular bone. And so when they're stimulated by parathyroid hormone, what they're going to do, and then a picture of an osteoclast is there. Whoops. There's one. So here's our little osteoclast. They're going to attach to the bone with this side of the cell. And basically, what they do, and you can see lots of nuclei, they have lysosomes, lots of them. So there's some there. And so what those are essentially cell stomachs. And so your osteoclasts have several stomachs, if you will, really high hydrogen content. And so when they attach to the bone, they're going to use that acid, that high hydrogen content, to break the bonds between the calcium phosphate crystals. And so they'll free up that calcium, and then it will, so once we've freed up our calcium, it'll then move inside one of these veins, and then circulate back to the heart, and then go to wherever it needs to go. So I'll get our blood calcium up. So once our blood calcium returns back within normal limits, then we'll stop releasing parathyroid hormone. So it works on that classic negative feedback loop. So blood calcium gets too low. In response, we secrete parathyroid hormone. Parathyroid hormone stimulates the osteoclasts. They free up calcium. Once blood calcium gets up high enough, we stop releasing parathyroid hormone. So we're back where we want to be. Calcitonin probably does the opposite. So calcitonin probably brings calcium back down. But only if you deliver it at pharmacological doses, so like only if you actually administer it in really high doses. So there's some question about what calcitonin actually does from a physiological standpoint. This textbook refers to it as being a hormone without a function. So one of the things I would say is that we're actually, surprisingly, learning a lot about bone over the last decade that we didn't know. So for example, learning a lot more about what it is that osteocytes do. So originally, and this textbook kind of hints at that, the thought was that osteocytes are just kind of space takers, that they just sort of were mechanosensors about whether the bone is stressed or not, but in general, they didn't really do much. But we're finding out over the last 10 years that they do quite a bit more than that, but they also have an endocrine or hormone function as well. So I think calcitonin, while we don't really know what it does now, eventually we're going to find out that it probably does something fairly important. A couple other hormones on there, leptin. Leptin is secreted by your fat cells, including inside of the marrow. And so leptin increases the activity of the osteoblasts. So leptin is secreted by the fat cells when they're full, tells you that your energy stores are good. And so when my energy stores are good, it's probably a good time to build bone. So leptin plays a role in stimulating the osteoblasts and building new bone. Serotonin is in the central nervous system, but it's also a hormone secreted by the intestine. And so when serotonin is secreted by the intestine after a meal, it inhibits the osteoblast. It actually inhibits bone production. So there are a number of different hormonal controls that cause us to either build up or break down bone. The primary one that I want you to know is parathyroid hormone, that causes us to break down bone to keep our blood calcium within normal limits. And then the other way the bone responds, or the way the bone remodels, is in response to mechanical stresses. So like muscles, bones adapt to loading. So whenever we repetitively compress a bone, we want to reinforce it, we want to strengthen it, and so loading of the bone stimulates communication between the osteocytes, and that initiates a signaling cascade that stimulates the osteoblasts to lay down additional collagen. And so, backing up one slide, where the osteoblasts lay down that new collagen, it's called the osteoid seam, and that's underneath the periosteum. And so where you've got that immature matrix where it meets the calcified tissue, that's the calcification front. So Wolff's law, you can see there, is named for a German physician from, I think he coined the term, or coined his law, if you will, in 1892. But you can see the Wolff's law there says the bone grows and remodels according to the demands imposed on it. So if we load bone, we'll lay down more bone. If we unload bone, so for example, if somebody is immobilized, like they got a cast on, or they're bedridden, we will demineralize bone. So we'll lose bone density. And so we see that in the case of hand dominance. So for most people, if you're right-handed, you have higher bone mineral density on your right side than your left. We also see that in the case of bone spurs, which are also known as osteophytes. So in this case, this person has a heel spur. And so what happens there is you've got your plantar fascia, which is a band of connective tissue that runs along the bottom of your foot. It originates there on your calcaneus, on your heel bone. And so if you've got lots and lots of tightness in your plantar fascia, so usually what happens there is this is in people that have to stand all day. You also see it in endurance athletes, but oftentimes it's people like hairstylists or factory workers that just are on their feet all day long and maybe in shoes that are not particularly supportive. Puts a lot of stress on the plantar fascia, and so it'll start to pull away from its origin there on the calcaneus. And so to secure that or to reinforce that, we'll lay down additional bone. So that's a type of bone loading, or that's a type of mechanical stress. And so then that's one of the ways, or one of the reasons you might see osteophytes bone spurs. And we talked about the training remodel. We talked about the shoulder. Remember that in the case of the humerus, because you've got that growth plate there at the surgical neck, if you get that repetitive external rotation in the shoulder, you can get a torsion or a rotation of the diaphysis, the shaft of the humerus, relative to the head of the humerus. All right, so let's talk about fractures, because they're interesting. One of the things on there, so fractures and breaks are the same thing. So I've had students oftentimes, and for the last 13 years, would come in and be like, oh, did you see so-and-so fractured their leg? And so In a lot of students' minds, a fracture is worse than a break. Like, oh, they didn't break their leg, they fractured it. Like, well, okay, but that's the same thing. Like, breaking is the more colloquial term, and fracturing is just the more appropriate anatomical term. So anyway, just know the two are the same thing. A fracture is not worse than a break, they're the same thing. So in terms of fracture classification, you can see that we can classify them based on their position. So are the two bone ends lined up or not? If they're not lined up, that's a displaced fracture. Completeness, does it go all the way through the bone or not? If it's a complete fracture, it goes all the way through the bone. And then skin penetration, if it's an open wound, that means that the bone actually went through the skin. And then obviously closed wound did not. The reason that's problematic, obviously, is if you have an open wound, now you have a source of infection or a potential site of infection. Right? Anytime you got an open wound, bacteria can get in there, and that can be bad. And so open fractures are worse than closed fractures in that they pose an additional risk. And then we'll talk about the location, appearance, or nature here in a second. So they are categorized basically by a combination of sort of the presentation and then the mechanism of the injury. So for example, and these are just kind of the common fracture classifications, and then there are sub-classifications under these. But the first type that you might actually hear is the one on the left, which is a comminuted fracture. The comminuted just means that there are 3 or more fragments. We tend to see those in older people because as we age, the calcium phosphate crystals get increasingly brittle. So one of the things is we're constantly turning bone over. I think the stat in the textbook said something to the effect of turning over 5 to 7% of your bone mass per week. But the reason we're turning bone over is that not only just damage and wear and tear, but also because if we just left bone alone after we initially formed it, again, those crystals get increasingly hard, so they get increasingly brittle. And so that just sort of happens across the lifespan anyway. So you tend to see in those older, more brittle, more crystallized bones, that's where you tend to see these comminuted fractures where the bone just shatters. The one on the right side there, a compression fracture. So obviously you just compress it, they're describing the mechanism of injury. In the spine, so that's a picture of a compression fracture on the spinal column. Typically you get those in car crashes, like a rollover car crash is where you might see something like that. Or you could see it in football, like in the neck, head down tackle. You might see a compression fracture in the vertebrae. It would be pretty unusual. Something else typically gives first, but it's possible. Spiral fractures, those are your common sports fractures. It's a good skiing fracture. Like you get your ski caught and kind of rotate. Because spiral fractures are a twisting of the bone. And so the reason they're sports fractures is, typically it's a change of direction thing. So somebody stops, changes direction. You can get where their foot gets stuck, maybe their cleats get stuck in the turf, something like that. And rather than a ligament giving out, in this case, the bone gave out first. On the right side there, a growth plate fracture or epiphyseal fracture. Again, in that calcification zone is where those are most likely to occur. And that one's a pretty bad one, just as an aside. So that's what you're looking at here. So this is the shaft of the femur. This is the distal aspect of the femur. And so that kid's leg is significantly shorter than the other leg because you've got the shaft of the femur is overlapping with the distal part of the femur. So his leg is probably an inch or two shorter on that side. So they're going to have to do plates and screws, and that's going to close that growth plate. And so then they're going to have to dress that on the other side because this leg is going to be shorter than the other leg. So that's a pretty bad injury. Depression fractures. Similar to a compression fracture, you typically get them in flat bones or it just kind of dents the bone. So you see those, as you can see there in the skull, struck by an object. Green stick fractures, I think, are some of the more interesting ones because if you work with kids, those are going to be the ones that you're going to see. So just like we talked about where as you go across the lifespan, the bones get increasingly brittle, before you reach skeletal maturity, not only do you have those epiphyseal, those growth plates, but a kid's bones haven't laid down quite as much calcium as ours have. And so their bones just aren't quite as hard as our bones. They actually have a little more bend or a little more give to them. So when a kid, falls out of a tree or falls off their bike or something like that, and they, fall on an outstretched hand, the bone is going to have a lot of bend to it. And on the traction side, on the side being pulled apart, it just kind of splinters like a green stick. So like if you go out and take a branch off a tree and try to break it because it's wet, it'll just kind of splinter, as opposed to a tree branch that's been laying on the ground, dried out for a while, will actually shatter. Similar idea here. So because their bones don't have as much calcium in them, they actually just kind of splinter rather than shattering. So you don't see comminuted fractures in kids because they just aren't calcified enough. So oftentimes, like if you're seeing, a kid falls on their arm and they're like, is it broken? One of the things you watch for is you get like a little like bruise there, or not, well, bruise too, but that's later. You get a little swelling pocket on that. And so oftentimes like, oh, okay, that's probably fractured. Then you get an x-ray. It's not, in kids, oftentimes it's not like super obvious. In terms of bone repair, so after you fracture a bone, fall on a hand or something. So one of the things you probably noticed is that bones have a really good blood supply. Not only do they have a really good blood supply, they got a really good nerve supply, which is good and bad. And the periosteum has a pretty good nerve supply as well. So bone fractures tend to hurt quite a bit because, again, bones are well innervated, so we're aware that it has been injured. But the good thing about the significant blood supply is we're really good at repairing bones. So whenever you fracture the bone, you're going to get lots and lots of bleeding at the fracture site, and that's going to form a blood clot, also known as a hematoma. So initially, you're going to get lots of bleeding at the fracture site, blood clot forms there, and that sort of lays down the framework for the repair that follows. So remember that inside of the bone, and also along the periosteum, you have some stem cells, some immature cells. And particularly inside of the bone, along those trabeculae, you have stem cells that can differentiate into osteoblasts, or chondroblasts, or fibroblasts. And so when you get a fracture, those stem cells are going to be stimulated by a signaling cascade to differentiate into a combination of fibroblasts and chondroblasts. And so when they do that, both of those things, the chondroblasts and the fibroblasts, start to lay down lots and lots of collagen fibers. And so that's what's going to form that fibrocartilaginous callus. So basically you're going to make fibrocartilage because of the chondroblasts that have migrated to the area. Then, very similar to what we talked about with the growth plates, you're going to get osteoblasts are going to migrate to the area. They are then going to lay down their matrix, will calcify that, and so that's when you get your bony callus formation. So this part on the far left happens immediately after the injury. In the first few days, you're going to lay down your fibrocartilage callus, and then by about the 4th week, you're going to be to stage 3, to the bony callus. And then kind of in that 4 to 8 weeks is when we get most of that remodeling that occurs to where the bone actually heals. The normal fracture healing time, depending upon the extent of the fracture, is somewhere between 4 to 6 weeks. Maybe a little bit longer, maybe more like 8, but typically in that 4 to 6 week window. Yep.
So, like, if you really needed to, could you, like, walk on a fracture with, like, a spongy bone in between? So, like, it's not recommended.
Probably, yeah. Yeah, I think it would be like you could do some because you want to load it a little bit, and that's going to provide a stimulus to help it remodel maybe a little bit faster. So you probably could, it's just not going to be very stable. So yeah. And actually, I meant to mention earlier, so one of the things, so remember when you compress a bone, it causes the osteocytes to send electrical signals. And so you may have seen, anybody seen an electrical bone stimulator, where you basically use an electrical current. And what that does is it tries to mimic that compressive signal, the way that the osteocytes would signal to each other that the bone is being compressed. And thus that causes remodeling. The idea is that if you put this electrical charge through the bone, it's going to stimulate the osteoblast activity. You'll lay down the matrix faster. It's kind of one of the ideas there. Those may be effective. I think they have some effect, but it's not a huge effect, or it doesn't really speed up healing time all that much. All right, last slide, made it. All right, so bone disorders. So if you can build too much bone, but that's relatively unusual. Typically, there's some hormonal disruption there. So a more common issue is that you have too little bone, if you will. The bone is not dense enough. So a couple of things can be going on there. So osteomalacia is just poorly mineralized bone. You don't have enough calcium in there. And in kids, it's called rickets. And so rickets is typically caused by either a calcium deficiency or more commonly a vitamin D deficiency, because you need vitamin D in your small intestine to be able to absorb calcium, which is why if you ever look at calcium supplements, it's always calcium and vitamin D. Have to have vitamin D to absorb the calcium. So if you don't have either of those things, can't get calcium into the bloodstream, can't get calcium to the bones. And so in a kid with rickets, what ends up happening is, again, they've got a deficiency of one or both. And so their osteoblasts are going to lay down all of that collagen. They're going to lay down all the matrix. but we just don't have the calcium to put between those collagen fibers to give bone its hardness. And so then when the kid stands up, and so the most common sign of rickets is a kid with, so this is actually an adult, but a kid with bowed legs like that. Because as they compress the tibia and the fibula, they're going to bend because they don't have quite enough calcium in them, right? So you're on the collagen, and collagen's kind of like a mop. It's kind of smushy. And so then you get a deformation of the bones. Osteoporosis is one you're probably a little more familiar with. It tends to happen in women. Can happen in men, but it's more common in women. So osteoporosis means porous bone. And so what you're looking at there is trabecular bone, normal trabecular bone on top, and then osteoporotic bone on the bottom. So osteoporosis is a loss of bone density. One of the reasons it happens in women is because of the role of estrogen in hanging on to bone mass. So estrogen plays a really important role in hanging on to bone mineral density. Effectively, what estrogen does is causes women to pull more calcium out of the small intestine. So it causes better absorption of calcium, but it also causes decreased bone turnover, causes decreased breakdown of calcium in the bone. Essentially, it inhibits the activity of the osteoclast. So you get decreased bone breakdown, increased absorption of calcium, so you maintain bone mass. But in women after menopause, so give or take after the age of 50, they stop producing as much estrogen, which then removes the protective effect of estrogen from the bones. So you get worse absorption or reduced absorption and faster turnover. And so then you can get a reduction in bone mass. There's a condition that's referred to sometimes in the medical literature, at least sports medicine literature, the female athlete triad. So what that is in female athletes, particularly in women's sports or in weight sports, so like cross-country runners tend to have this. So, or soccer players, I've seen it, or read case studies in soccer players. In cross-country runners, it is advantageous to weigh as little as possible, right? You don't want to carry a bunch of extra fat mass because that requires you to use more energy to move that mass. So you want to be as lean as possible if you're a cross-country runner. And so trying to be lean, combining that with running 60 to 100 miles a week, however many miles they're running, you're going to get an energy deficit, sometimes a pretty substantial one. And so in your elite female athletes who are running 60 to 100 miles a week, who want to have their body fat as low as possible, sometimes if they get their body fat too low, so below like 12 to 14%, normal for women is about 25% in a college-age woman. So if they get their body fat below 12 to 14%, what you can end up with then is an alteration of the menstrual cycle. So they won't have their normal monthly cycle. And the reason that matters is during the monthly cycle, you get a peak of estrogen and a peak of progesterone. And if the monthly cycle goes away or gets disrupted, you get that peak of estrogen goes away. And again, estrogen has an important protective effect on the bone. So you can get reduced bone mineral density because of that lack of energy intake and a lack of body fat. So those things are all kind of related. So the female athlete triad, different books describe it a little bit differently, but the gist of it is oftentimes it's described as disordered eating, so not necessarily a full-on eating disorder like bulimia or anorexia, but disordered eating, body fat's too low, or actually, so it goes from disordered eating to amenorrhea, so lack of menstruation, to then reduction in bone mineral density. Why does that matter? So that matters if you've got a woman who in her early 20s has fairly low bone mineral density. Most people maximize their bone mineral density by the time they're age 25-ish. And so if you start in your 20s with low bone mineral density, by the time that woman hits 50, now she essentially doesn't have as big of a bank account to draw on whenever she, goes past menopause. And so then she's more likely to get osteoporosis. If your bones are thinner, more likely to fracture, and so then that becomes problematic. All right, that's bones. Anybody got any questions on anything? Okay. So we'll start on the hip on Monday.